I don't know. And I'm wondering what is it now? So yesterday I was able to work for like 8 hours. Yeah. I got from the doctor. But it was well, I don't so I'm like, Mom, clean your voice. I'm trying to figure out.
But I like
Good afternoon, everybody. How is everybody doing? Good to see you again. I hope you enjoyed last week with Daniel. And I also understand that there's been some requests to go over quiz 5. Particularly the information on life tables and how to use the information that's provided to you within the life tables, and we will do that in a minute. Want to remind you or direct your attention again to the syllabus. We have one more class next week, which we will continue with epidemiologic study design, and then a reminder that October 14th, you'll have exam 1, and that just reminds me that I will get the list out to you of individuals that will come in for the 1 o'clock seating. Sounds like dinner arrangement. The early seating and the late seating at 2:30.
Raise your hand.
I'm sorry?
Non-life student raise their hand.
Thank you very much. We're on. There's. Hi, Fred. What's up?
The sound is going in and out. We can't hear it.
Okay. I will try to speak loudly and hopefully.
I don't think it's you. I think it's WebEx because it disappears completely for 10, 15 seconds and then comes back.
Okay, we will. You'll excuse me for one moment so that I can get spoken.
It did just then.
Excuse me for one moment. Sorry. Thanks, Fred. We've got a call in to the WebEx folks, and hopefully they can adjust or help us with the audio. So we've got exam coming up on October 14th. A reminder to online students, there are still a few of you that have not provided your proctor information, and we need that before you can take your exam. So we're entering into a new area of epidemiology as we begin to study epidemiologic study design. And the goal of our reviewing epidemiologic study designs is to get to the point where we can learn what study designs are most appropriate for certain research questions. We're also going to learn the strengths and weaknesses of each of the epidemiologic study designs. And that goes, that's related to their appropriate use. Epidemiologic study designs are applicable to many fields, not only public health, but they can be used in business. For example, as you are going through the life table exercises, that principle is used in the insurance business as they try to calculate things as length of life expected and how much you should be paying for your insurance premium. Epidemiologic study designs are used in medicine, laboratory sciences, many applications, and that's why it's always informative to have an epidemiologist on a team to be able to contribute our study design. So as a start, once again, both as a reminder to me and to you, the session's being recorded. Speak loudly and clearly. And so as I mentioned, there's some items to review. Let's start with quiz number 5, and then we can go on with any other specific questions that you have regarding anything that you've been reviewing up to this point. And so, let's see, I believe there were seven items for quiz number 5. And as an epidemiologist, I want to compare the baseline characteristics of the patients who withdrew. And we can also categorize withdrawals as loss to follow-up, withdrew from my study with those who had completed follow-up in order to, and you have 4 options here. Check for changes in prognosis over time. Check whether those who remained in the study represented the total study population at the start of the study. Test whether randomization was successful, or all of the above. And so, go ahead, sure.
Check whether those who remain in the study.
Okay, and so the choice was option B. Check whether those who remained in the study represented the total study population at the start of the study. Do I hear agreement, dissent? I see a lot of up and down shaking of heads. So it looks like there's agreement among those of you in the class today. And why would this be important? Yes.
If the sample size is not a good representation of the total population, it's harder to make generalization about the total population.
Okay, and so you're alluding to sample size because you've had some loss to follow-up, and so the number of study participants initially enrolled has dropped, and so there's actually several issues that are important that are sort of rolled up into this question. When you are doing a prospective study, or sometimes called a longitudinal study, when you're following individuals over time, one of the things that you want to concentrate on is how to retain study participants over time. Whenever you begin to lose participants, your sample size is reduced. If your sample size is reduced, you may begin to get into an issue of not being able to do certain types of statistical analyses because your sample size does not meet the assumptions of some of the more robust statistical techniques. And also, as you begin to lose study participants, your study population may begin to change in terms of their characteristics. And so if the patients who withdrew are within a certain category, perhaps it's the younger study participants, the older study participants, maybe it's gender-oriented, you need to check to see whether those who remained in the study represented the total population at the start of the study. Loss to follow-up, withdrawal, dropout, that is a potential bias that can occur in a study design, a longitudinal study design. And if the individuals at the end of the study, if their characteristics are not similar to the characteristics at the start of the study, they no longer are representative of the study population. Okay, your study population, remember, is a sample. It may be a sample of individuals with a certain type of disease. It's never going to be all of the individuals with a certain type of disease. It's a sample. We want that sample to be representative of our target population. Gets into the issue of internal and external validity. You want internal validity within your study, which is the issue that this question is alluding to. Loss to follow-up can have an effect on internal validity because it may change the characteristics of the total study population. You've got this total study population at baseline. You're able to describe them in terms of average age, race, ethnicity, income level, severity of disease, whatever, however it's best to describe your study population. And then you want to make sure that those who finish the study, whether it's over a day, over a week, over months, over a year, you want to make sure that the individuals that finish the study are similar to those that start, and to retain internal validity. And then if you lose internal validity, most likely you are going to lose external validity also. Any further questions or comments about this first question? Yes.
I just have a question about option A. Is it because it's not possible because they've dropped out, or is it because you just assume their prognosis is going to be different, or why is, could you just explain that a little bit?
Sure. Okay. And so I want to compare the baseline characteristics of the patients who withdrew in order to check for changes in prognosis over time. And so how are you thinking about that? My goal is to compare baseline characteristics of patients.
So they're gone. So is that
right? I guess I want to get to your thinking about how that relates to prognosis.
I guess because I was imagining them receiving treatment and then dropping out, which would affect prognosis, but there's really no way to measure that if they're not part of the study anymore.
Right.
So
right.
Okay.
Right. Hi. Yeah. How are you today? Good. One of our online students that is participating synchronously, is saying that our volume is dropping in and out.
In and out. Okay. Is it just that one user, or is...
I think he's maybe the only one on.
Okay. I want to close that session.
No, please don't close that.
Let's turn this down, so. Okay, good response there. The microphone is right there.
Correct.
If there's any noise in the background that may be taking focus off of your microphone, that may be what it is because the air is running right now.
Okay, so maybe we can check in with.
This screen was going black too. Like it was completely disconnected. Like he said that it was like, it's not that the volume was going in and out, it said it was completely disappearing and then coming back.
Okay, thank you for the clarification.
Okay. Let's see if I can. It's okay if I just stop sharing your screen for a minute.
Sure.
Make sure that your network connection is okay. Okay. Sorry, it's a little different than what I'm used to using. I just kind of wander around and find what I'm looking for. At this moment, I don't see anything I can adjust. All your lines are turned up exactly as far as they can go.
Potentially.
Yeah, I can't hear it, so I can't hear the session because I'm not in class. I can try to contact the guys who are listening in, right? They should be listening in on your classes over learning, and they have access to listening in, and maybe we can troubleshoot it then. But right now, it's not sitting on just for you. I'm sorry.
That's fine. I appreciate it.
We'll get back to you and let you know. They can possibly get started with different calling. That might be also another option.
Thank you.
Sorry about all this.
Okay, other questions about item 1? Yes.
So, if we found any baseline difference in baseline characteristics between who left the study and who remained in the study, what are we able to do then?
What are our options? So the question is, let's say we do have dropout or withdrawal, and the study is finished and we're checking our characteristics. What can we do? Do we just say, throw up our hands and say, oh my goodness, just can't do anything? Checking for that, as I mentioned, is checking for bias associated with dropout or withdrawal. And we potentially can adjust during the analysis phase of our study. There are 2 times when you can control for confounding bias, other extraneous things that you project might occur based on the type of study that you're doing. You can either do that during the design phase or you can do it during the analysis phase. Once you get to the analysis phase and you begin to try to control for confounding or for bias, the statistical techniques become more sophisticated, more complicated, but it can be done. Another issue to consider is the number that have dropped out. If there is a large number of dropouts, you may not be able to do much then. Let's say it was a treatment study with a medication. You may learn that those that were on the treatment arm, they dropped out because there were multiple side effects. And this is information that is worthwhile. Once you do this experiment, perhaps you now can say it is not worth going any further into, getting this treatment or drug on the market, because once it's in the real world, individuals are not going to maintain the regimen. So there are things that can be done. Any other questions? Okay. Median survival time is defined as the length of time that half the study population survives. And you have the option of true or false. True. So who can provide a definition of the median?
The median is like the middle number.
Right in the middle, 50, 50, half, half. Yeah, okay, good. The relative survival rate is the ratio of, so whenever you see relative, okay, ask yourself, relative to what? Okay, means you're going to be making a comparison, okay? That's how you can think about or remember relative risk. You're comparing two populations. Relative to what? Relative to the reference population. Relative to non-diseased population. Relative to the non-residents of a community. Okay, the relative survival rate is the ratio of the four options here, number of people who have the disease to the number of people in the general population. Okay, why would you not select that as the best response? Okay, and is it providing you with any information regarding survival? Okay. So let's not even think about A. B, observe survival in the population with the disease to the expected survival if the disease were absent in this same population. Talks about survival. Talks about survival in two different groups. We've got a population with the disease and a population without the disease. But let's see. Let's go on to C because that says something about survival also. Observe survival in the general population to the expected survival in the diseased group. Is it B or C? It's B. And why is it B?
I think the key is absent in the same population that we're comparing to the group if it were absent.
Okay, and it's your definition of your relative survival rate. What is it? That's all this question is asking you. What is the definition of the relative survival rate? And as you all select, B is the correct answer. Okay, now we're going on to the 5-year survival rate. So the 5-year survival rate is used to express prognosis, used in evaluating treatments for cancer, the percentage of patients who are alive 5 years after the treatment begins or 5 years after diagnosis, all of the above. Okay, so we have many chiming in as all of the above. Agreement, disagreement? We've got agreement. And so the 5-year survival rate can be used for multiple things. Prognosis gives us some information about prognosis. It gives us information over a period of time. It can be a 5-year, it can be a 3-year, it can be a 10-year. It gives us information that can be used for, once again, prognosis, physician, information to tell his or her patient that may or may not be helpful as they discuss treatment options. But once again, you need a point in time, you need a starting point. Starting point could be at the point of diagnosis. Starting point can be at the point of treatment. Starting point can be anything, and its prospective goes over time. Okay. When using person years to express prognosis, one needs to be aware of the fact that the risk is assumed to be the same in any person year observed. Okay, so these are assumptions. You're all familiar with assumptions. particularly for statistical techniques. Statistical techniques have a lot of assumptions that you go down and you say, my data set has met that. And so person years to express prognosis, risk is to be assumed the same in any person year observed. True or false? True. And it is true to allow us to calculate or to combine person years into the denominator. Okay. There's no weighting here. If a study subject participated in January and February, we need to assume that their risk of person months in January and February is the same as participant B who contributed November and December. Now we can combine person months from January and February, November and December, put them together, and assume that the risk is the same for those periods of time. Now, this is level 1 of using person years to express for the calculation of risk. There are, once again, sophisticated techniques that you don't have to worry about in which risk can vary among person year, person month, person time observed. But that's just in case you get one of those questions while you're talking about this at your next social event. Someone might question you and say, no, that's not the correct assumption. Right now, for Epi 1, that's the assumption that we are accepting and the normal. Okay. The Kaplan-Meier method uses predetermined time intervals to estimate the probability of death. True or false? False. Okay. And you selected false because, yes.
They're not predetermined, it just kind of creates a new interval once one person dies. We don't know what
that's correct. We can't predict what's going to happen, whether or not it's going to be a dropout or a withdrawal, a death. And so you just need to go with whenever your step occurs, that's what you consider, what you enter into your formula. And once again, we want you to have a general understanding of the Kaplan-Meier method. Okay. You will not be asked to calculate the Kaplan-Meier statistic given a table of numbers, but to have the knowledge to be able to answer a question like this about Kaplan-Meier. Why it might, when is it used? Why might it be used? What type of information does it give you? Questions?
I just have like a sort of all questions, but are we going to have, since you're talking about what we need to know, we don't need to know, are we going to have a study guide at all?
Yes, there will be a study guide, and thank you for that reminder.
Thank you. We love study guides.
Yeah. It's a real short one. Not to add to any anxiety, so it's short. And I'll remember to post that by tomorrow. Okay.
And long study guides are not bad either. They would lessen the worry. Just to, but other
All right, let's vote on that.
No, but I have a question though.
Yeah, sure.
The formulas, because like calculating life, you learn all of that, and I see that there were formulas and the labels and things like that. How many formulas do you, like, will we know what formulas we need to memorize? Or
We're
like,
not memorizing formulas, right?
Oh, straightforward.
Yeah.
Not memorizing formulas. I want you to understand, focus on the principles and concepts of epidemiology, the principles and concepts that you are reviewing from chapter 1 through chapter 10 of Gordon. Okay.
So when we're not going to be doing a lot of calculating.
Not going to be doing a lot of calculating. Complex calculating. The 2x2 table. Who can handle a 2x2 table?
All of that.
All can handle a 2x2 table. Okay? 2x2 tables get you far in life. All right, here we go. Here is the
Yes. Oh, well, I think that this is most confusing because in the book, I think, or maybe it was in the science project, we had it like one way where it was like, you know what I mean? And then they had it.
Okay.
And so I don't really know which way to read which one. Does that make sense?
Okay. Yes, it does.
Okay.
Yes, it does. Yes, I understand. Yes, no. When you're used to looking at something and then someone then, you know, does a 180 degree on you, you're like, understood. Okay. One thing I want to point out is terminology, and I think this is what may be part of the confusion. And I want to direct you to page 124 on Gordon, okay? It's just write this down if you don't have your book now. But table 6.6-8 and table 6-9, okay? These are two tables that provide you with information on two different things. Okay. In table 1, we are talking about probabilities for a single year. 1 year. Probability for the first year. That's it. The second year. The third year. Okay? And so probability of surviving the first year and the first year only. Okay, that's where you get your P1, your P2, your P3. That's your percentage or your probability. Okay. Now, when you're asked the probability of surviving for years, multiple, S on the end, okay? That's when you know you have to multiply your probabilities, okay? And I think in terms of getting down to the final answer is, I think, folks, I think you may have gotten to like 88.6 thinking that that was it. But to get to what is the probability of surviving for 3 years, plural, that's when you need to multiply your probabilities, okay? Your probability of surviving 1 year times the probability of surviving 2 years times the probability of surviving 3 years. You multiply those so that you can get the multiple years, okay? So that's how I remember the difference between the two, how you might be asked, yes.
So to work this one out, you would first need to get the probability for the first year, then the probability for the second year, then the probability for the so it really is 4 separate steps to get to the answer.
Mm-hmm. 1, 2, 3, and then the fourth one being multiplying. Yes, yes, yes. And so what would you what would you have to do for what is the probability of surviving for 2 years? you get the probability for the first year, the probability for the second year, you multiply it. Anyway, so I just wanted to point out page 124 in tables 6.8 and 6.9, and then let's see what I did here. Okay, so yes, here we go, stepping through this item on quiz number 5. So you have the first, you calculate the probability of surviving the first year. So let's go back and look at what 328 divided by 370 is. Okay, so we've got the first year. Got years of treatment, 2010, 2011, 2012. Okay, so, you know, I think that's a good point that you brought out in terms of tables sometimes, you know, going horizontally, sometimes things are going vertically. First, orient yourself with the table. Say to yourself, okay, what do the rows mean? What do the columns mean? You only have to deal with the rows and the columns. The only thing that you've got in your table. So if I look at year of treatment, so time is going down the rows. I look across, okay, in 2010, 200 patients were treated. We've got 175 were still available in at the first treatment. Got information for the second treatment, information for the third treatment. In year 2, 2011, 120 patients treated. What happened to them? Year number 3, 50, and 43. Now, see what's happening. You get this diagonal because if you were entered in year 2, you can only contribute 2 years.
Okay, is this like the whole diagonal thing?
Yeah.
And like, so I don't know if you can like, can you perhaps see that? How it's like 2001, 2002, and it goes down that way, but then on the next one, it starts, like I don't understand that switch at all.
Okay.
And I don't know if I'm the only person who thinks that that's confusing, but I think that it's like that's how it starts, and then when we go to calculate, we get, it just doesn't make any sense to me why this column had all of them.
Well, all right, your year of treatment is 2000.
Okay.
And it's got, so 2000 should have all the information. 2001, you're going to be missing one.
Okay, so these are then going up this way? Is that what you're saying? Okay, never mind. I guess. Figure it out somehow.
I think the vertical and horizontal is flipping.
But what does that in it say? Like, they just formatted it differently because you would understand it. So maybe it's not easier for everyone to understand.
Right.
Year 1, 2000, there's the one that year. You only have one that's 7.
Okay.
So when they put it in like first year in treatment, it's like the first year's year 1.
Okay.
So it's like 2001.
They changed the name actually basically instead of saying first year, second year, they still use the calendar year as first year.
Right.
If you're looking at them all like this is first year, this is
So what your colleagues are telling you is year 1 is 2000. Okay. Year 2 is 2001. Year 3 is 2002. And so they're being labeled that way rather than using the 2000, 2001, 2002. It's not different information, but I can see where it can be confusing.
Okay.
Yeah, no, because, yeah, whenever you see something flip like that, yeah. Okay, so let's go back to the probability of surviving the first year. We're getting information about 1 year only, and so your denominator, once again, what's the numerator, what's the denominator? Your denominator is the your total, and your 328 is your numerator. Divide that, multiply by 100, which I kept that. It would have been 88.6. Okay. The second year, you have 245 divided by 285. 245. And why is it now? Why did your denominator change from 328 to 285?
This is where I'm getting stuck.
Oh, okay.
I don't get the denominator when it changed after the first year. The first year is easy. Numerator, I got it.
Right. Okay, so what do we do after the first year? Why does the denominator change after the first year? Go ahead.
You have the study group that joined in 2012 that shouldn't be accounted for in the denominator because they only studied for 1 year. So you have to subtract 43.
Okay, so let's think about this, because this is, folks are having, are still thinking about this. So how else can you explain that, or say it? Go ahead.
Are you saying why is it confusing?
No. No. We don't want to add that there. We just want to know, why does the denominator change, or why do we use a different denominator for year 2?
For the first year, the 43 people who survived in 2002, who were starting 2002, those 43 people don't have a result for the second year. I mean, we don't know how many of those survived in the second year. So that could be eliminated from the denominator because those were not part of the study.
Okay. How else would you describe that to a colleague? I'm just trying to get different ways of describing it. So, you know, some people think differently. We all think differently. Our logic moves from here, there, whatever. Go ahead. Yes.
I'm not going to change it. I want to read from the book.
Okay.
So, but 43, the ones who were enrolled, we have no further information because they were only observed for only 1 year. So we have to subtract 43 from the denominator because we don't know anything about them, whether they died or lost to follow-up. Don't have any idea.
That's right. So we're beginning to get some similar information. As we don't know anything about them, so it's not fair to include them in the denominator. We don't know what the outcome was. Let's see. Go ahead first.
I have a question. How come, so I'm talking out loud in my brain, how come that's the first year when they've gone through 3 years of living? Like 2010, 2011, 2012, but they only survived for 1 year. Is that start backwards? Like
The first year is 2010.
So wouldn't that all be flipped? So it's like 43 is at the top, and the top line should be at the bottom?
Go ahead.
Okay, so when you started studying, like 2010 was like the first year of a group receiving treatment.
Yes.
So your group of 2012, like your study's not infinite. It's got to have an endpoint. So by the time, like 2010, when they stayed them for 1 year, at the very end of the study, so they were on follow for a year. Does that make sense? No. So when you started, okay, so you're doing a 3-year study, right? At the end of 3 years. So 2010, when you study them for 1 year.
Yeah.
That's your first column. So by the time a group started in 2012, you only had 1 year to study because it was a 3 year.
people.
Yep, totally different.
Okay. Yeah, that keeps 50 people being studying in 2012.
Yes. Okay, so that's a good question in terms of, are these different people?
Yeah.
Yes. So you're the total period of time for the study, it's a 3-year study.
Okay.
Okay, it goes from 2010 to 2011. And recruitment is going on recruitment and enrollment is going on for 3 years. And so 200 entered in 2010, 120 entered in 2011, 50 entered in 2012 for a total of 370. But we don't have 3 years of information for all of the study participants.
Okay.
It's dependent upon the year that they were enrolled. Okay.
Okay, so I guess the way that I was thinking about it is like the first year of the study, that's 2010, didn't make sense for the people from 2012 to be in there. But instead of thinking of it that way, it's like it's the first year that they're studied. So like all of those were at different times. Like in the first column, all of that was gathered at different times, but it's just like the first year that they were studied.
Yes.
Oh
Okay.
my God.
Okay. Yes, I know. Very good. Yeah. No. I think I see where you're coming at now. Right. And so you're saying, well, if they didn't enter in 2010, how can they have information? How can we combine this information? Yeah. Okay. We can combine this information because we're kind of ignoring the year that they entered. And we're just saying all of these 370 individuals entered the study. They all have 1 year of information, right? They all have 1 year of information. 320 of the 370 have 1 year of information, 2 years of information, and then these 200 only have 3 years of information. But if you entered in 2012, you can contribute to the denominator 1 year of information.
Okay, so then why aren't you subtracting 50? Why are you subtracting 43?
Because we're doing survival rate.
Because okay.
Okay. So do these probabilities begin to make more sense?
Can you go back to the previous slide?
Yes.
Can I walk up there and point to what I think that is just weird?
Mm-hmm.
So
Yeah,
I'm going to switch to the next year. So we're doing year 2. It's always, the numerator is always this. It's always those people who survived, right? And the denominator is always the previous year minus this little bump that's in the way. So the third year would always be numerator 100, always be 245 minus this bump. Is that true?
Yep. You like that? Does that work for everybody? Good. Okay. And then, if you have year 4, year 5, same thing. All right. Okay. And so we had, once again, okay, so this is probability for surviving the first year, second year, the third year. But when you want to know, which is very different, first year is different from the second year, it's different from the third year, you can see how the probabilities differ. And then, so now you want to put all that information together. And you want to know what is the probability of surviving for 3 years. It's almost like an average, and you kind of have to average it because the probability for each of those years differ. And so you multiply the probabilities. Right now we're talking about 3 years, it can be 4 years, 5 or 6 years, depending on how much data you have. And so that's why the answer for this item was D, 50.7. So as you read, ask yourself, okay, are they referring to a probability for a single year or for multiple years? Single year is a lot easier to calculate, right? Well, not necessarily. Once you go past the first year, then you have to do minus that to rearrange your denominator. But if you're focusing on years with an S, then you know you have to multiply your probability. Okay. Go ahead.
Would you ask, like, what's the probability of surviving through the third year? Does that still accumulate, multiply?
For surviving 3 years. Yes. Yes, cumulative. That's what you want, cumulative. There's another term if you want to use cumulative. You need to multiply, right, your probabilities. Not just a single year, but cumulative. 1, 2, 3, multiply your probability.
Surviving for 3 years.
Okay, yeah.
So that was the end of that. And I'm going to break here so that if you have additional questions, let's talk about that now. Talk amongst your colleagues, and then in 5 minutes we'll come back to see if there are still questions to resolve, and we will address those questions. Great. Okay, so here we begin with the randomized clinical trial as an epidemiologic study design. And this design really is in a class of its own. As we think about study designs, we can begin to categorize them, and that helps us to determine the most appropriate design to use for our research. And one method of categorization is experimental, non-experimental, or experimental and observational. The clinical trial is an experimental study design. And that can have potentially negative connotations for individuals that are perhaps inpatients in a hospital, and a research assistant approaches them and asks them if they would like to be in it and to participate in an experiment. You know, what does an experiment bring to mind?
Danger.
Danger, right. You're going to do what with me? What else?
Curiosity, ignorance, like you don't know what's going to happen, you're just trying it out.
Because what did we learn about an experimental design? You have those that are treated or receive a device or there's some type of intervention versus what? placebo, standard of care, nothing, placebo. And so there's that area of sometimes everybody wants to get the intervention sometimes, and so there's actually, oh yes, I will participate because I can get the drug. Nothing else has worked thus far. I can get the new treatment. And so you see there's some very interesting ethical issues that surround randomized clinical trials. Now, are randomized clinical trials ethical? If they are done properly, thank you. And that, yes, and that is the key. If they are done properly. All research now is reviewed by what are called institutional review boards, IRBs. All academic institutions, research organizations, businesses, firms that conduct research involving human subjects and that also receive funds from the federal government must have an IRB. IRBs don't just exist at academic institutions, but they exist to protect human subjects, to make sure that the experiment is, the proposed experiment is going to be conducted properly, that it meets certain criteria, that if there is an ongoing treatment for a disease or a condition, and you have a new treatment, you don't necessarily have a placebo, meaning nothing. If there already is a treatment or standard of care, your new treatment is being compared to standard of care. Now, we also have a sort of top-down order of robustness of a study design, and the top is the experimental design, the clinical trial, but there are many conditions, many instances, many research questions for which the experimental design is not appropriate and cannot be used. And I do not want to sell the randomized clinical trial as the best study design. That's not the type of question that we're trying to answer for a discussion of study design. It is a study design that can potentially be used, but then we ask that question, is it appropriate to use the randomized clinical trial? What are the alternatives? And we'll begin to learn more about the alternatives as we go through the next few weeks. I think that the clinical trial is perhaps the study design that is most recognized by lay individuals, and perhaps the design that more individuals have been exposed to in terms of being asked if they would like to participate in a research study. And so conducting research with human subjects is is very difficult. You never know whether or not they're going to show up, what they're going to do, if they're going to take the treatment, all sorts of things. It's very hard to control people. And so the experimental design started with things like agriculture, determining if I plant corn in this plot and I add this nutrient to it and I compare it to corn that I put in this plot over here, which one does better? It's, no humans involved, but you start developing 2x2 tables. You think of that acreage of farmland, and the farmer divides it into plots, and his or her first plot is a 2x2 table, so that you can begin to create or include different variables that will affect the growth of that corn. And you get into things like factorial designs, where you don't have to do multiple experimental studies in order to take into consideration multiple variables. You can lay out your agricultural plots in ways in which you can do one experiment and answer many questions. That design was then brought into the laboratory, and I think it's potentially at this point that makes human subjects leery of whether or question whether or not they want to be a participant in an experiment. We think of terms like the laboratory rat and what happens to the rat in the laboratory as the investigator is doing her experiments, or the other terms of guinea pig, that you're being taken advantage of and you're being thought of as a guinea pig. Fortunately, we have regulatory steps that must be considered in a very thoughtful manner, so that we can conduct clinical trials in an ethical way. We build on our experiments. They begin preclinically. They do start in the laboratory. We might be initially trying to determine what the effect of a drug is on cells or on animals before we bring them into the human population. And so we think about these experiments as preclinical experiments. And so one of the, as it says, the essential characteristic of an experiment is the fact that the investigator has control over the study, has control over the randomization, has control over the exposure. But not always. The perfect experiment, the investigator with human subjects will have control of those things. But There are instances when a study participant is randomized to treatment A, and the study participant goes home and never takes treatment A, comes back and reports that he or she, look at my empty vial. I have taken all of the study drug during the first month. Now I'm coming back for my second vial of study drug. Once the human subject is out of range, many type of things can happen. We talk about things such as contamination. The study subjects may sort of do their own crossover while they're within the experimental time. And it's all of these issues that the investigator needs to try to anticipate could happen. And that's when we start designing sort of interesting techniques that will allow us to monitor the study subjects when they're sort of out of our line of vision. You've all heard of the medication vials that have tops that with little microchips in the top of the vial that records every time that the top of the vial is taken off. An attempt to monitor the subject as they proceed through the study. If the experiment, for example, provides instructions that the study subject is not to participate in cigarette smoking during the first month of the trial, we may bring that study subject back and collect some type of biomarkers of nicotine exposure. And so these are the attempts of the investigator to maintain the classic experiment with that study subject. Besides the investigator having control, the other important component of the experiment is that we have a control population, a control study arm, a control group. This allows us to compare outcomes in those that received the treatment, the intervention, the device, versus the control that did not have that exposure. The experiment can be done at the individual level. Clinical experiments can be done at a community level. There can be community interventions where you have a control community, an intervention community. You expose the intervention community to media, billboards, commercials, whatever. You have no such exposure in the control community. With the goal of seeing if whatever you did, whatever the intervention was in the treatment community, did it work compared to control. You want your control to be as similar to your treatment group as possible. There are phases of clinical trials, which is very important because you don't want to go too far too soon or without reason to go to the next step. Everything that is tested, whether it be a medication, a device, and an intervention, does not work. And so you want to learn that as soon as possible with as few participants as possible also. You don't want to expose a large number of human subjects to an intervention that is not going to have a positive outcome or is not going to be successful. So through these phases of clinical trials, you learn different pieces of information along the way that allows you to assess and determine if you should go to the next step. And so you start with your phase 1 trial, and it is a relatively small trial. 20 to 80 is often even larger than what might be used in certain instances, particularly if it is in an area with a lot of experience. The oncology field is primarily based on clinical trials and continually testing new drugs, new treatments, and often can learn with very small numbers whether or not they ever get out of phase 1 in that venue. But primarily trying to evaluate safety. As I was mentioning, you don't want to expose any more than necessary to a treatment or drug that is not safe. Yes.
So phase 1 sounds just like very kind of up in the air, if you will. So how, because this part is evaluating the safety and kind of coming up with a safe dosage range, how does the IRB like approve that? Because isn't that kind of a little bit shaky? You know what I mean?
Sure. Remember, at this point, we don't know whether or not, let's say it's a drug. We don't know if the drug is going to work or not. But we may have a condition in which we don't have many options for treatment. And the treatment that we do have has many, many side effects. It's almost detrimental to the individual. So we are willing to continue our investigation, continue our research, and try to find new treatments that will have be less detrimental, have less side effects, and we weigh the risks and benefits of a phase 1 trial. And that is what happens. Because you participate in an experiment does not mean that there are no risks. If you read a consent form, there are terms such as there is a risk of death. Okay? So it is, once it gets by the IRB that understands these issues, it's now up to the participant. Perhaps the participant includes his or her family, and that it's just the the basic principle of an informed consent. Make sure that your study subjects are informed, that they understand, that you spend time on that informed consent. They are complex, difficult, sometimes getting the reading level low enough to, and I'm not saying because folks are not educated, but for, for some of these treatments and drugs, the family is in a state of, we will do anything, we will try anything, and you want to make sure that they understand the risks, the benefits. Sometimes there are no benefits, okay? There are experiments, clinical trials that are done with human subjects where the informed consent says there are no benefits to the study subject, okay? And then but there may be benefits to the next individual or society as a whole. So, great question, and the role of the IRB is very important. The role of the investigator to present a full picture of why this drug should be tested, why it should be evaluated for safety, why it's important to determine a safe dose range, and to identify side effects. And so, as I was saying, that a drug may never come out of phase 1. Drug development is very expensive. That's why our medications are very expensive. That entire discussion of our pharmaceutical companies just doing it to make money, or are they actually, is this how much it actually costs to develop a drug? Okay. Yes?
Like, for drugs, when it's a completely new composition, don't the pharmaceutical company have to do those testings on animals first, and then when they are certain that certain dose is safe or something, and when they expect some definite reaction from that drug, and only then they are allowed to do phase 1. Isn't that happening? Like,
that's correct, and we discussed, we start at the preclinical level. Mm-hmm. And in the preclinical level, we may be using cells, we may be using animals, and that's often, that's what will occur, but humans are not.
But that's the
animals.
basis by which the IRB decides.
Definitely. And that is why it's so important for the preclinical investigation to be as rigorous as human subject investigation. There may not be an appropriate animal model available, and so all drugs are not initially tested on animals per se. Another issue is those animals that are closest to humans for certain types of diseases, their numbers are limited, and thus testing in them is very expensive. And so macaques, other type of animals, you just don't have the opportunity to do that sometimes. But hopefully that there has been something done preclinically to inform us where to start once into the human subject study. Okay, so past phase 1, now you can go into a larger study. You've got the justification. Perhaps there have been multiple groups that are testing this drug in human subjects. So you've got some replication. Group in California, another group in Massachusetts, some folks in other countries have tested the drug, the intervention in phase 1. You can incorporate the information into the report to document what occurred. Were there any deaths, and were they could they be attributed to the intervention? Were they not attributed to the intervention? Often phase 1 studies are performed with study subjects that are at the sort of severe phase of their disease, and so the death, the side effects may not be directly attributable to the drug. That's important to know also. Phase 2, a little bit larger, to determine if the intervention is effective, and then once again to further evaluate safety, because a true study of the safety of an intervention needs a huge number of individuals. We're never really able to evaluate safety of an intervention really until we get into the post-marketing phase, where it's being released to thousands, millions of individuals, and that's when we start seeing pop-up of deleterious outcomes that then are reported back via registries to the FDA, and we get that monitoring. It then becomes, you might think of it as an outbreak investigation, where you begin to see these clusters of unsafe events, side effects. As the years go by, you get larger and larger and larger numbers, and you may then need to pull the drug back and add some information to the insert of the packaging. Phase 3. Now, rather than testing a little bit more of the effectiveness, monitor side effects, once again comparing it to standard of care, and then collecting information that will allow the drugs to be sold, placed on the market. Randomized clinical trials of phase 3 are often done in across multi-centers. Most often, a single center is not adequate to perform the phase 3 studies. And then the phase 4, once again, post-marketing studies, or also called post-marketing surveillance, because that's basically what you are doing. You are doing, rather than surveillance of a particular disease or condition, your surveillance is for outcomes, side effects of the intervention. And so, yes.
If a drug is going through a clinical trial and it goes to, let's say, phase 3, and then something is noted, and does the company have to start from the beginning? They can make adjustments to the drug. Do they have to start from phase 1 again?
That's a good question, and it just depends on what happened and how much you are actually having to change the intervention, and it may be necessary to collect that early information to go forward, and it may not. Once again, that would be a very specific question with a specific response, depending on what the circumstances were, what changes are being made. overall goals, assessing safety, relative effectiveness in order to be able to release the information to general population to determine whether or not it's an evidence-based intervention. Now, throughout the development of randomized clinical trials, the outcomes that were classically recorded and monitored and used as determining whether or not it was a safe and effective intervention were really very much clinically and medically standardized. There is a new avenue of looking at interventions that is now termed patient-centered. Randomized clinical trials are performed under often very sterile conditions, under conditions that do not necessarily represent what happens in the real world. And so you may do a randomized clinical trial, you've got your study results, it's a success, and then it gets released into general population, and it's a failure because the environment has changed, and there are now other influences that weren't necessarily being measured or taken into account for during the very sterile period of the randomized clinical trials. And so we've got a group, an institution, the Patient-Centered Outcomes Research Initiative, or PCORI, and that has become very important for the evaluation of interventions, medical interventions, clinical interventions, treatment, to hear from the patient, him or herself. We're telling you to take this medication. We think it's working. It looks like you're getting better. And the patient may just say, I really don't feel any different. I can't function. I can't, get up in the morning. I can't walk down the street. Maybe you're doing some blood draws, testing some proteins, doing some pulmonary function tests, and according to the medical and clinical outcomes, the individual may be fine, but is she doing well? Is he doing well? What is the patient concerned about? Are they having difficulties swallowing the pill? Is the pill too large? Do they have to drink gallons of liquids in order to feel that they've gotten the pill down? The taste, the odor. How many times do the meds need to be taken? Once a day? 5 times a day? 16 times a day? A very common issue when we were first beginning to be able to treat HIV. The medications were not tolerable. They had to be taken multiple times a day. Some treatments needed to be taken with food, others without food, some in the morning, evening. It was very complex for an individual to live with the treatment because it disrupted their entire day. They just felt immobilized, couldn't go to school, couldn't go to work. And so now we realize that in order for an intervention to be truly successful, it needs to be acceptable to the individual, to the human subject. And so this is a sort of a new a new phase for clinical trials to listen to the patient. As the data are coming in, there may be what is called interim analyses. Once again, we want to make sure that the trial does not go on any longer than it should, and even though it may be, we see some statistical significance, it may not have a clinical significance, and I think this is very important in terms of maybe there's a statistical significance, but the patient does not feel as they have seen a significant change in their life after taking the drug or following the intervention. And in terms of interim analyses, I'm going to be discussing in a few minutes a very recent trial that was stopped sooner than what was expected. The trial was expected to go on for about 5 years or so, and then after about 2 years, looking at the data, realizing that it was not fair to keep the intervention from the control group. Okay? And so once again, weighing the issues of risk-benefit, the trial was stopped and intervention available to all. And this is it here in terms of my little contribution of epidemiology in the news. This was a sprint trial, and it was stopped this year, September 11th, looking at systolic blood pressure intervention trial sprint. Expected to conclude in 2017. This is a huge trial. Study investigators did not anticipate that the study would so suddenly screech to a halt after just a few years. And this was the trial that was primarily looking at whether or not that target of keeping one's blood pressure as an adult below 140 for systolic. And this was, once again, a multi-center randomized controlled trial. And there were, and I'm giving you the basics of the trial. There were additional research questions that had some other arms and other analyses depending on some subgroups that patients were randomized to. But it primarily compared two strategies for treating systolic blood pressure. One that the regimen was to maintain a blood pressure below 140, and then the comparison regimen of maintaining systolic blood pressure of less than 120. And so this was an extremely significant trial for us to watch and learn from because of the prevalence of high blood pressure here in the United States. 79 million adults in the United States. 1 out of 3 have high blood pressure, and these figures are based on the cutoff of 140 or above, now realizing sort of the potentially arbitrary cutoff of 140 or above. And so SPRINT was proposed as the definitive clinical trial in non-diabetic hypertensive patients to determine whether lowering systolic blood pressure to less than 140 was designated, that was designated by NHLBI expert panel in 2007, quite a few years ago, as the most important hypothesis to test regarding the prevention of hypertension-related complications. Because we all know that uncontrolled hypertension has some serious consequences, heart attack and stroke, to name just two, and, you know, sort of all around the fact that there are still so many adults that don't know that they have high blood pressure, that they've never had their blood pressure measured. Non-invasive measurement doesn't take long, doesn't hurt, and also something that we can control. So it is very important to have high blood pressure screening. We see that offered sometimes even at fairs, and they're not even health fairs, but it's something that we know is a problem. We know that it is prevalent, and there are ways to treat high blood pressure, whether it's behavior modification, whether it's drugs. So there was a randomization of a little over 9,000 men and women to the SPRINT trial. Sample size, a priori sample size calculations were to enroll at least 9,250, so they're right at their target. Inclusion criteria. Now, I want you to focus on the inclusion criteria, okay? Because, all right, so SPRINT was stopped early, and it was in the media as, okay, now we have learned something very different from what we've heard from our healthcare providers. Everyone needs to get their blood pressure below 120. Is that statement true? Read the criteria. Trials are done, studies are done with certain study subjects that enroll, that have characteristics. Okay, so we cannot generalize the findings from SPRINT to the general population, right? And so those that participated, greater or equal to 50 years of age, the systolic blood pressure, 130 to 180, and they had to be at risk or one or more of the following, okay? So these folks were not the healthy individuals walking on the face of the earth. Presence of clinical or subclinical cardiovascular disease other than stroke, at risk of chronic kidney disease, at risk of Framingham risk score for 10-year CVD risk, greater than 15%. And so the Framingham risk score is based on the Framingham heart study. That is the basis for much of the information that we know about cardiovascular disease. Those data were used for NHLBI to determine systolic blood pressure of less than 140 could be applied to the general population. And so this is why once the SPRINT was stopped, one further clarified, if you have questions about your current treatment for high blood pressure, get in contact with your healthcare provider so that you can discuss these issues as to whether or not the results from SPRINT apply individually to a patient. So let's look at the randomized clinical trial design. This was an experiment that screened over 14,000 individuals and found that 10,000, a little over 10,000 were eligible for randomization. Some were lost between determining eligibility and being randomized. Perhaps some of those individuals read the informed consent and decided that they did not want to be randomized. Perhaps whatever decisions people make. And so they had 4,678 were randomized to the intensive blood pressure regimen, trying to keep blood pressure less than 120 systolic blood pressure, and another 4,683 that were randomized to the standard blood pressure regimen of maintaining blood pressure less than 140 systolic blood pressure. And then during the screening process, you always come up with some that screen out as ineligible, and for various reasons. You want to make sure that you only enroll eligible individuals into a randomized clinical trial. All studies, research investigations, whether they be experimental or non-experimental, need to be based on a hypothesis. And the primary hypothesis in this case, as you see, treating to a systolic blood pressure target of less than 120 compared to systolic blood pressure target of less than 140 will reduce composite outcome of non-fatal MIs, acute coronary syndrome, non-fatal stroke, and death from CVD. So these are our outcome measures that were counted as the study progressed over time, prospective, longitudinally, and basically, in a nutshell, what you're doing is you've got, this is a two-arm study, so you've got Group A with the intensive intervention, Group B with the standard, once again comparing the intervention to standard of care, and you are comparing the rate of these outcomes as they occur over time, keeping in mind the denominator, keeping in mind withdrawal, keeping in mind dropout, all of those things that could influence the outcome. Does randomization make sure that study groups are equal in terms of their characteristics?
Oh, no. It increases the likelihood, but it can't ensure it.
Very good. Yes. It increases the likelihood. It does not mean because you have a randomized, or you use randomization, that your two groups, your three groups, however many groups you have, that they are exactly similar on all baseline characteristics. It's a tool. It helps. Your groups will more than likely be similar, but they may differ on some characteristics. You may run a test and find that your p-value is less than 0.05, but that's okay. That's okay, because now in the analysis phase, you can control for that difference. Okay. If you can use randomization, use it. It's a robust tool, but it's only a tool. It is not perfect. Primary analysis was Cox proportional hazards regression to compare time to first occurrence of the primary CVD endpoint between randomized groups using all participants under the intention to treat principle and two-sided test at the 5% level. So, the primary analysis needs to match the primary hypothesis. Okay, so the primary hypothesis, the primary research question drives everything. It drives, it drives the study design. It drives the analysis. And so you want to make sure that your study design matches your hypothesis or research question, that your analysis matches the research question or hypothesis. And so since the investigators proposed to compare time to first occurrence, they selected a analysis technique, which just happens to be named Cox proportional hazards regression. That statistical technique is able to compensate for time to first occurrence because those that did have a primary outcome would not have it all at the same interval of time. And so you need to determine whether or not the group A is having a outcome sooner than group B. Let's see, between randomized groups under the intention to treat principle. What is that principle, intention to treat? Say it to yourself. This is that whole thing of human subjects. You intend to treat them. I intend to treat them as study group A, but they go back home and they don't follow the intervention regimen. Okay? But if they were intended to be in group A, even though we know that they didn't follow the directions, we still need to keep them in group A. Okay, we intended that they be in group A. They remain in group A.
So an investigator wouldn't drop a participant who disclosed that they weren't doing it?
That's correct. That's correct. That's correct. Because you can start getting into the game of, oh, I think I'll not include this one in the analysis. I won't include this one in the analysis. I won't include this one in the analysis. We hope that in terms of secondary analyses that one might include that all those caveats are described. These are the patients that weren't included in this analysis and for this reason. But your first line of a randomized clinical trial is to use the intention to treat principle. You know, quite strict here in terms of using a two-sided test, not going in a priori thinking that one condition would be better than the other. Participants who got their systolic blood pressure below 120 had a lower death rate and fewer heart attacks and strokes than those whose goal was a blood pressure below 140. And this was just very surprising to the investigators. Once again, remember this is a multi-center trial done across the nation. I think the closest group here was Winston-Salem, known for their CBD research groups, just really all very top research centers that participated in Sprint. And so let's take a break. I'm going on to a different topic here. We're jumping from CBD to HIV. So 5-minute break.
I like it. It's a golf course. Really? I was just well, it's a skirt. The legs really set it off. Golf course
They had to it's just like, don't have to. Wait, what is it supposed to go to the yeah. But then it eventually came to me, and I felt like there's yeah, we said that was really thinking I had okay, so I just maybe a little bit in the house. And then let's just
That's what my teacher told me. Yeah, I'm just gonna say this because I know, I don't know.
And I did what we did because I wasn't looking.
I think those
Not once, you don't have it. I know.
But it was, they did do it really cheap, so we can go display. I'll just start by making like a really super large. I was allowed to get a subway. I was getting so angry. I can't do big things.
I like that. I like but
The grade A, that's like, good, but. And then, you reminded I think everybody has orientation or review. Yeah. Live at everyone and think, oh, so good.
Okay, I've been suggesting that you, after you go through the chapters, you mark down 2 or 3 things that you have questions about or you would like more discussion. Let's do that for the randomized clinical trial, experimental design. Any questions? Any items? Any confusing points? Yes?
Can you just clarify, like, we talked about how randomization within the study group was, it would help, like, make the groups closer. But in the book, it was talking about, like, in phase 4 clinical trials, no randomization was involved. So when you're looking at groups, I'm just trying to, like, incorporate both of those concepts together. I mean, if you're trying to compare 2 groups that are at the phase 4 clinical trial, how is randomization looked at? Right. If it's technically not included, but then it can be done.
Right. The phase 4 post-marketing surveillance design is very different from the true experiment, and randomization is not incorporated. The phase 4 surveillance collects information on outcomes, side effects, deaths that are occurring in a population. It's an observational study, and so you are primarily analyzing data with the concept of observed versus expected. Okay. And so within a population of a certain size, we expect so many deaths. Well, if you begin to observe more deaths than expected, it may be time to take a look at the drug or the intervention. These are data that are coming in from the general population, so no randomization involved.
Okay.
Yeah.
Okay, so then, in a different scenario, the epidemiologist looking at cases that have been done like in the past, where you've already had the trials and you're just analyzing data from that perspective, you could construct like the 2x2 table and actually do things that way?
That's correct. If the randomized design was used, you can retain the randomization, and perhaps you are asking different questions than the primary question. Studies are often done, we're talking about these large multi-centered studies that are most often funded by National Institutes of Health. All of those data are retained in a repository by NIH, and anyone an investigator that was not involved with the study can submit a concept sheet and say, I am interested in such and such database from such and such study, and these are my primary research questions. These are the data tables that I'm going to construct. These are the analyses that I propose to answer my questions using the data from the study. And it is important to maintain all of the study elements in the secondary data analysis. Now, there are times when there is a sort of a neutral result after a clinical trial, an experiment, meaning that there was equal outcomes between the two groups or among the three groups. You can then, if you're not seeing differences in the two study groups at the end of the trial, and you have considered the potential bias or confounding, or you controlled for baseline differences, but you get to the end of the study, no group is, you're not seeing success over one group or another, you can then convert it into a cohort study and just say you combine the groups, and then you can disregard the randomization at that point and treat them as one and just treat it as a single observational study rather than a randomized control. What other issues or comments regarding the randomized trial? Yes.
The book talks about the number of patients needed treatment rate. It's like it's an equation, and it talks about rate untreated and rate treated. Well, what is rate? Like, is it measuring mortality? Is it measuring morbidity? Does that matter?
You can measure anything with the rate. Yeah. So it can be the rate of the outcome, the number of, the rate of MIs, the rate of deaths, the rate of blue noses. Yeah. Does that answer your question? Okay. Yes.
You're talking about the intention to treat principle.
Yes.
Is that kind of the opposite of allowing the unplanned crossover to occur? Like, with the intention to treat, saying, okay, you're going to stay in group A, that's where you belong. But unplanned, I just wanted to make sure.
Sure. The unplanned crossover, right, is the patient deciding that they're going to do whatever they're going to do. Intention to treat would keep them, during the analysis, it would keep them in the group that they were randomized to. Yeah. They may have crossed over. Yeah. That's that contamination that can happen, and that's why you're, as an experiment, you are trying to maintain control over your study design. But anything can happen with human participants. What else? Yes.
How do you classify people? Say you're not studying mortality, you're studying, I don't know, how a drug affects arthritis, and a person in a study is in a car wreck and dies. Where do you put that in withdrawal? How do you deal with the
in terms of the at analysis, and in terms of statistical speak, it's called a censored event. Okay. Anything that occurs that keeps you from continuing to collect information on that individual. And so depending on how many censored events within the same category, sometimes you can actually put them in their own category, but for that example, you would treat them like a dropout. You know, you say that they were in a car wreck or something like that. It had nothing to do with the study, so they're just out. You can use their data up until that point, and then they're just no longer participants. And you know, with any large study, there's going to be varied things that could occur to study subjects. But, you know, and it's difficult to follow study subjects in terms of you know, some you lose contact with. You know, there's we used to be able to use what was called reverse telephone directories. I mean, we don't even have telephone directories anymore, and so it is getting, you know, it's hard to do longitudinal studies. let me talk a little bit about a little bit more about the format and organization of large trial groups. Clinical trials are resource intensive. They're expensive because most often you cannot do them at a single center. And so, starting from sort of mid-'80s or so, I was at a research institution in the Texas Medical Center, and we were able to participate with NIAID, National Institute of Allergy Immunology, Allergy and Infectious Diseases, and this was the institute at NIH, and still is the institute, that is in charge of the research agenda for HIV/AIDS. And at that time in the United States, we had a significant epidemic of pediatric HIV/AIDS, primarily infants born to women that were infected with HIV. And so our primary goal initially was to come up with a treatment that would block the transmission of HIV from mom to infant. And none of the centers that were part of the pediatric ACTG could answer that question by themselves, and so we participated as a group, as a pediatric ACTG. And this meant, in order to appropriately answer our questions, we needed to follow standard protocols, meaning that each center would have the same study subject criteria for enrollment, would have the same, use the same data collection tools for collecting the data, whether they be abstraction from medical records, from laboratory, interviews with mom, the same protocol for follow-up, and we were dependent then on centralized centers. There would be a central center for randomization. We would, for example, identify an eligible mom, often at delivery, and we would have a randomization number we would call, and we would say we're ready to randomize or consent and randomize a mom. Give us the what group she is in so that we know which protocol to follow, so that we so that you can then communicate with our pharmacy, and the pharmacy would be the location of the investigational drug, where they would do all of the blinding or the masking of the blood drug that was necessary. Remember, we talked a little bit about blinding and masking in the chapters so that the investigators do not know if mom received drug or placebo. Basically, so that investigators or observers don't become biased and see things that, they want mom. They want mom to be healthy. They want baby to be healthy, and let's hope she got the drug, this, that, whatever. Anyway, pharmacy would mask or blind the investigational drug, hand it off to the study team so that the regimen could start in labor and delivery. So that there was centralization for randomization. There was centralization for data management and analysis. As a clinical center, we would collect the information, enter the information into a standardized package, data analysis package that was basically facsimiles of the data collection documents. We would put all the responses in, the medical record information in, whatever was required by the standard protocol. All of this being followed via a procedures manual. Anytime a research study is conducted, there is always a procedure manual that the study staff use and follow, the investigators use and follow. This allows you to generate valid, reliable data. It has instructions for how to conduct all the measurements, how to administer the data collection documents. Data would go centrally into one database from all the study centers, about 18 or so. Each entering a study patient when a study patient that met the study criteria sort of appeared at their door. Depending on the protocol, the study centers would enter different numbers of study subjects, or a center may select to do one study and not to do another study. On the basis of trying not to have too many competing studies going on at the same time. The groups often come together at least 2 or 3 times a year at a central location in order to discuss the study protocol. What type of issues are you having? These are the issues we're having. How have you resolved? How are you following up your women? What type of incentives work at your study location? But anyway, using that standardized protocol, using the standardized methodology, using the standard database allowed us to pool our data, analyze our data, and eventually, stop the transition from mother to child of HIV here in the U.S. And then primarily, pretty much globally, and was a real success for the clinical trials networks. As I mentioned, the networks are still in existence, but they've changed dramatically. Many of or all of the sites in the U.S. have partners internationally. You need to go where the issue is, and are addressing some very different challenges that we never thought we would be addressing. Early in the epidemic, in the pediatric epidemic, infants were dying during infancy. We never thought that we were going to be able to celebrate their birthday at 6 years old, or their birthday when they were 13, or their birthdays now that they are adults. So a very good example how well done, ethically appropriate clinical trials are done on a large center-wide national basis can really help the health infrastructure of a country. And it was the most appropriate study design to use to find answers quite quickly And also, in addition of the sort of the clinical aspects of the trials as they moved forward, we would have subgroups, pharmacology, virology, immunology, infectious diseases, where they would be working in concert of the clinical trials going forward, of doing the basic science necessary so that we would have the next clinical trial to step in. Okay, so now we're able to save infants. They're not dying at birth, but we know that they're harboring the infection. What's our next step? Well, what's the treatment that will be safe and effective to treat HIV during childhood? And then we started rolling into cohort studies, longitudinal studies, prospective studies, which allowed us to follow a group of children that were receiving antiretroviral medication, and how would these drugs have an effect on their cognitive abilities at 5 years of age, at 10 years of age. And so you can see the sort of the layers of interesting, well-needed research that can be layered onto an experiment, can answer additional questions rather than questions regarding intervention. There are most diseases, conditions as defined by NIH have clinical trial networks. You might be familiar with the oncology networks, both adult and pediatric oncology networks, diabetes networks, cardiovascular disease networks, and all really done at that multi-center level. And so you can see the importance of having a standard protocol, whether you are one center or multi-center. What else? I'm going to open it up to anything. What questions do you have? Stratified randomization. Is that a concept that you got? Okay, so you can divide potential study participants into groups, maybe gender, male, female. So you have your group A, group B, and then you apply randomization to group A, randomization scheme to group B. Stratified randomization. You're stratifying on a characteristic. You could stratify by age, young, not so young, old, and then you've got 3 groups randomized within each of those groups, so that if you don't have stratified randomization, you have one pile of envelopes. Someone calls you and says, I need a randomization envelope. You pass it out from one pile. If you have stratified randomization, you have 2 piles or you have 3 piles. Okay, if we're doing gender, stratified randomization, I have 2 piles of envelopes. I'm the centralized randomization center. I get a call from one of my clinical centers. I need a randomization envelope. Okay, this is stratified randomization. Are you randomizing a male or a female? It's a female. Okay, let me go to my female pile. I give you one from my female pile. The next one calls, it's a male. I give from my male pile. And so there's multiple randomizations going on for stratified randomization. That may be, and why would we have stratified randomization if we think that randomization kind of gets our groups at least comparable? Well, we may know so much about the disease or the condition or whatever we're working on that there is an interaction of outcomes or a variable that we know that potentially a drug may work quite differently in males and females. But we, want to get this all done at the same time. That's one reason why we may stratify, just to get that very large influence or interaction out of and we can do it at the design phase rather than having to worry about it during the intervention phase. What are historical controls? Records from the past. Can you randomize? It's pretty hard. Can't randomize, and so you can potentially see weaknesses of historical control. Usually not used as a robust study design if you do not have to use historical control. So much changed over time. It's almost like don't even think. Yes.
I had a quick question about factorial design.
Yeah.
Is that actually even used? Because I'm just thinking of all sorts of cases where we might think that their mode of actions may be independent, their outcomes may be different, but there might be some biochemical interaction that we don't know exists, but can affect, the outcomes. So I was thinking that's kind of a dirty design. Is that really done?
It is, and actually it is it should be used more often than it is. Because it's a strong design, it's a valid design, it's a good design for certain things, right? Some designs are more appropriate for certain questions than others. What happens is sometimes, and I see this more at the preclinical stage, is those folks in their wet lab will run an experiment with one factor. Then they're using 100 mice. And then they'll run the same experiment, except they'll change a factor. And they're using another 100 mice. Well, they could have just answered 2 questions with 100 mice rather than 200 mice by using an appropriate factorial design. And so, once again, it's the whole thing, what's the question and what matches best with the question. And factorial designs are robust, proven, appropriate statistical technique can be mapped onto that design, and it is used, it is fine. That's a good question. I see where you're coming from in terms of would you potentially miss something by using a factorial design. And, once again, it depends on the question. I think we began to discuss ethical issues. I brought that up initially because of the question that every now and then pops up in the news of, was this ethical? When investigators from the U.S. go to different countries to conduct clinical trials, that's often a point where ethical questions pop up. We need to consider the environment, the context in which we are doing the experimental design or randomized controlled trials, and we must make sure that what we are proposing is acceptable to the population where we're going. The question of coercion pops up in terms of incentives for participating. How much money is appropriate for someone's time for participating in a trial in terms of their environment. Is it coercive? Are they participating for the money only? And we don't want to create that situation. Any other? Yes, good.
The book didn't really address this, but I just had a question around the ethics of when the study's over.
Mm-hmm.
You know,
Mm-hmm.
like if somebody is receiving treatment for something and it's successful,
Mm-hmm.
and then the study ends,
Mm-hmm.
what are the ethics around taking them off that treatment before it's actually able to be marketed and available to them if they're actually surviving because of it?
Yeah, great question. And usually at that point, what happens is for a period of time, the maker makes that drug available to the participant for a period of time until, it does come onto the market, and also makes it available to the other arm that was not receiving treatment. But once again, it's up to the participant as to whether or not they wish to continue or whether or not they want to take the investigational drug. So, yeah, great question. Okay, all right. Yes?
What about in that case if someone in the trial wasn't receiving it, but they were like, I don't want to be part of the control anymore, like I want that drug, I see what it's doing. Would it then be made available to them because they were partaking in the study, or just, they'd be just like,
Not until the study ends. Yeah, because, until the study ends, you don't know whether or not it is successful or not successful. Yeah. All right. Oh, one more.
What about that time in between, though, from when the study finishes to the time when the drug might become available?
Mm-hmm.
If they did see that, and
Right.
they were in the study, but they were under control.
Right. They will make it available, or they will try to make it available. Thank you very much for your attention. Thank you for your questions, and I look forward to seeing you again next week. We'll get out the list of assignments for your exam time, and also study guide information. Bless you.